to do the land acknowledgement, please let me know. I think it's appropriate for everybody around the table to express their thoughts around land acknowledgement and the challenges that are out there for us as a health unit with respect to fair and equal treatment. So as we meet today in this fall season of reflection and change, we acknowledge that we are gathered on the traditional territory covered by Treaty 20, the lands and waters of the Mississauga and Anishinaabe, part of the Williams Treaty First Nations. We recognize their enduring presence, knowledge, and care for this land since time immemorial. As the leaves change and the harvest is gathered, we give thanks for the gifts of the land and for the opportunity to live and learn here together. As the seasons remind us of balance and renewal, we also reflect on our shared responsibility to uphold the spirit and intent of Treaty 20 and to work in partnership with Indigenous communities to support the health and well-being of all those who share this land. So just a note on today's meeting, there will be no live stream today due to staffing capacity. The audio line is open and the video will be posted on YouTube. Also like to remind members that you can volunteer to provide the land acknowledgement in two open meetings. I was happy to do so tonight. Are there any declarations of pecuniary interest other than that's in the agenda tonight? Seeing none, if anything comes up during the meeting, let us know and we'll deal with it at that time. Moving to item 3, adoption of the agenda. Are there any amendments to the agenda? If not, can I have a motion to approve the agenda as circulated? Councillor Richardson, Warden Clark. For discussion, all in favor? That's carried. Thank you. And we'll go to our regular minutes of September 11th, 2025. The minutes from the previous meeting have been circulated. Are there any amendments? If not, can I have a motion to approve the minutes of September 11th? Councillor Lachuka, moving it, seconded by, I get somebody on the screen, Dr. Makicha. All those in favor? Are there any business arising from the minutes? Not aware of any. So now we will move to item 6, Medical Officer Health Report. And Dr. Pickett, take it away.
Thank you, Chair Black. Good evening, everyone. Thanks for joining us here this evening. I'll keep my remarks short this evening because we're also going to hear from Dr. Bocking on fall respiratory season updates, including COVID, flu, RSV, and also measles, which you may have seen in the news last week. Outbreak, the largest in recent history and one of the largest in the world, was declared over last week, which is good news, but doesn't mean we won't see more cases as measles has risen globally and we'll continue to get some imported cases. A few items. So we're continuing, obviously, this evening. That will continue, as we mentioned, in the September meeting on a quarterly basis. We also are going to introduce in the November meeting our first quarterly program report since merging, which is great, and I really appreciate the hard work staff are doing towards bringing that report and starting to report on a quarterly basis on indicators. That report will be a starting place and iteratively refined over time, and I anticipate as we have a new strategic plan, we'll have some real thought into the future reporting needs to the Board of Health. So we'll see that first in November. Upcoming in the next few weeks are also a number of presentations that I'll be doing with various members of the senior leadership team. And Chair Black will be a number of those presentations as well to the local funders. So today I had a presentation to the Northumberland County. I'll have a presentation to the City of Port Lakes on the 21st. The City of Peterborough, October 27th. County of Peterborough, November 5th. Hiawatha First Nation, November 6th. Haliburton, November 12th. December 3rd, Alderville First Nation. I think we're just finalizing December 1st for Curve Lake First Nation. And so, yeah, at those presentations are speaking about the new brand and our merger. So Lakelands Public Health, the accomplishments that we've had so far in the merger. We'll be speaking a bit about public health issues, drawing in some data locally to each of those geographies on some of the social determinants of health and health equity. We'll be speaking about the budget for 2026 and also reminding folks that we have a survey that's now open for the community to fill out about the new health unit brand and where we're going with the strategic plan. And so that survey, will make sure that link is recirculated to everyone. It would be great if you could all share that to your constituents so that community members are able to provide input on where we're going strategically as a health plan. That's really early engagement. We're going to do much more wholesome engagement, including more surveys and town halls and other forums into the new year as we get to the next stage in strategic plan. I also just wanted to briefly mention that on November 18th, we're going to have an all-staff day. We will, as the agenda is finalized for that, invite the Board of Health for a portion to be able to meet some staff and perhaps share a meal and hear about some of the work that we're doing and some of the progress and achievements staff have made. But it's usually a way for the board to connect with staff. So that date is the 18th, but the kind of timing on that will be circulated ASAP, but hoping you can hold that till then. We also, with thanks for most everyone has completed the survey of interest for committees and chair, vice chair appointments. We'll discuss that not tonight, but in the follow-up. And one note I just wanted to make was in follow-up discussion with the chair and vice chair last Friday, because of a number of areas of need, there's an interest in at least assigning members to a standing committee for governance related issues into 2026. So at least pre-populating people's names. You'll see in the code of conduct tonight, there's potentially some relevance. There's relevance in selecting chair, vice chair, and committee membership. And for next fall, for the biennial performance appraisal for the medical officer of health, for myself, there's a need. We know that folks are incredibly busy, so we don't want to burden with additional meetings, but pre-populating people and then having meetings ad hoc is only as needed, not just a routine quarterly meeting, but might be a meeting or two next year at most, sort of as needed standing committee. With Ron Cecil, we were thinking that would be important and helpful. And that's the end of my update, unless there's questions. Thanks.
Yeah, thank you, Dr. Figgin. If I could just add to the governance thing, I think most of us that are on other not-for-profit type boards, there's a governance committee that meets to deal with issues, and some of the issues that are covered off in the policies we're talking today about should go through a governance committee, and you want that pre-populated with names ahead of time. So if it's a difficult issue, members might not want to be on the committee at that time. But if you're pre-populated and you're there, not that it's going to happen a lot, but for things like performance reviews, recommendations around the board positions, that sort of thing, it will come up. And I just think, and Cecil, I think, agreed that having that board ad hoc set up would be a good way moving forward to on the governance. Yeah, we'll bring a terms of reference to November. So just a thought, Mayor Logan.
Thank you. And North County Council, I just want to thank Dr. Gibb for showing up today, and they did him and Matt and Steve, I believe it did a great job, and we appreciate it. Some lively discussion, and it was very, very good. So thank you very much.
Thanks for seeing that.
Thanks, Mayor Logan, for the comments. I heard it was lively. Unfortunately, our county council meeting was exactly the same time, so I wasn't able to attend that particular one, but I get most of the rest, I think. So any questions on Dr. Pickett's update, Councillor Joyce?
Not a question, just to let you know that Employee Day, November 18th, that's also our council day. Yeah, so
We'll look at timing.
Councilor Richardson and I usually spend that morning trying to scramble myself.
Right.
Ready.
And in the
1
past,
o'clock kickoff, so yeah.
and for you, Chair, in the past, not all board members have been able to make, and we kind of actually have different practices, and we're trying to figure out what it looks like to have some all staff together going forward. It was hard to kind of pick on a day, and we have to figure what that looks like going forward.
Yeah.
But we at least wanted to extend the invite, so.
Yeah.
I understand you're presenting at, Fourth Lakes next Tuesday.
Next.
And Council, you're there, Councilor?
Oh, I'm in DC, I'm there. but-
Okay, I'm not, so I apologize for my absence, but it's the one council meeting I miss every year, so you're totally.
Right.
So,
Thank you.
wish you the best.
Any, Mayor Rogel, yeah?
Real quick question, through you. The meetings that you're having with, other, like Alderville, for example, is it board directors invited to go to them?
Through you, Chair, I think that obviously most of those meetings are open. I think on the Alderville front, maybe we could connect offline and think about that. I think it would be worth some more conversation, because I don't think the practice of kind of like an open meeting is necessarily the same in that context, but perhaps there could be some opportunities. So maybe we could discuss.
It is their council meeting that we're going to, so in their council meetings are open.
Mhm.
Yeah, okay, we'll follow up on the Mayor.
Yeah.
Thank you.
Any other questions or comments? Okay, can I get a motion to receive Dr. Pickett's update for information? Thank you, Mr. Johnson and then Mayor Logal. All those in favor, it's in hand. I lost everybody on the board, so for most of them, let's see who's putting their hand. So the folks that are on, a couple of people. So if you are wanting to ask a question, just speak up, please. So we know. Thank you. All right, so Dr. Pickett's going to introduce the next topic.
Well, I actually, I'll just turn over to Dr. Bocking.
Yeah. All right, wonderful. Dr. Bocking, go ahead.
Choking on salary, I gotta work for you. The first one. Got some salary, I don't have respiratory. Are you doing an intervention? Okay, good evening, everybody. Welcome to the Lindsay office again. So happy to be speaking to you this evening about the fall respiratory season. You may have seen a media release last week, which was our first locally acquired case of influenza across the region. So I think this is hopefully timely, and we hope that you can also share some of the messaging out among your communities. So things that I'm going to cover today, so a bit of what to expect for this season, the role of Lakelands Public Health and what we do to support prevention of transmission of respiratory infections across the region, and then speak very briefly on some highlights related to immunization and the annual report from the Chief Medical Officer of Health. So this graph has a lot of squiggles in it. The black line is represents the proportion of visits to emergency departments that are related to respiratory infections. So moving from left to right, this is a snapshot of last year's respiratory season. So respiratory season starts in August, is when surveillance starts, and then goes for 12 months. So you'll see that that black squiggly line slowly increases as the number of people that are presenting with cough, fever at emergency department increases. This follows a typical pattern every year, with a peak last year. It was in January and a very slow decline. So this is one measure that we look at to follow what's happening with respiratory season. This is another measure. So this is the number of outbreaks that were responded to by the health unit for the last 5 years. The blue line is the number of COVID-19 outbreaks, and the orange line is the number of outbreaks from other respiratory infections, which also includes influenza. So you can see in 2022, that high peak from COVID, that was in the height of COVID days, that has slowly come down, although I want to highlight that that's obviously not zero. And last year, there was an almost equal number of COVID-19 outbreaks declared as there were other respiratory infections. So COVID-19 still plays a very large role in the burden of respiratory infections that we see globally, really, not just certainly in our region. So the role of public health and respiratory season is not a short event. This is actually an all-year event. We're now in the top half of the circle, which is in the response phase. So this takes place over autumn and winter. But there are activities that happen in spring and summer. This is a full annual cycle with expectations and requirements laid out by the ministry for the role of public health in the work that we do. I've highlighted here 5 of our major components that we have a key role in coordinating for the health system, which includes surveillance, immunization, infection prevention and control, outbreak management, and communications. So with regards to surveillance, as we've brought 2 strong organizations together, this has actually been an initial area of work as we begin to harmonize our approach to both collecting information on respiratory infections and how we report that back out to the public for respiratory infections. Both legacy organizations had information available on their websites. We now have one website for Lakelands Public Health. That meant that we needed to combine our information to reflect the entire region. Both organizations had pre-existing respiratory dashboards where we reported on RSV, COVID, influenza immunization. And this was paused over the summer as we didn't see significant amount of activity, and is just being launched, if not today, then by the end of this week, a new respiratory infections dashboard that reflects the entire Lakelands Public Health region on the new Lakelands Public Health webpage. This new dashboard, I've taken a small screenshot on the left-hand side, is a reflection, includes both COVID-19 information, RSV and influenza, in general, what we call syndromic surveillance information, so proportion of people presenting to the emergency department with respiratory infections. It includes test positivity, and you can filter by geography, which now includes Peterborough City and Peterborough County. On the right-hand side, you'll see, and people will be familiar with wastewater surveillance data. So historically, the board for Peterborough Public Health funded some specific ongoing wastewater surveillance activity in the city of Peterborough in partnership with Trent University. So that information is still maintained on the Peterborough Public Health website. We do not have wastewater information for any of the locations in Northumberland County, City of Forthville Lakes, or Halliburton when the province stopped funding wastewater surveillance over a year ago. So this will come back to the board for future discussion related to funding for wastewater surveillance as we move to the future, but we try to still have it at least captured through the website so that people are aware. Apologies, the slide transition is a bit sticky. So moving to immunization. Huge portfolio and huge role for public health. And one of the things that I think most people realize is the amount of behind the scenes work that goes on to ensure that we have a safe and effective distribution implementation system for immunizations. So I've listed the other things other than just putting needles in arms that public health is responsible for, such as annual fridge inspections for every fridge at primary care providers that provide influenza vaccine. Public health is responsible for vaccine distribution and inventory management for all primary care providers for all influenza COVID-19 vaccine, management of cold chain breaks. And then, of course, we do provide clinics through the health unit for, in particular, those people that don't have access to a primary care provider. Respiratory immunizations become more and more complicated every year with the addition of, thankfully, additional vaccines. So last year was the introduction of RSV vaccine as part of our arsenal to fight off respiratory infections. This is an at-a-glance slide in terms of eligibility for different vaccinations across the age group through the respiratory season, and I'll talk really briefly about each of the different types of vaccines. Okay. Thanks, Wendy. So influenza vaccine, currently, those people that are high risk or priority populations are able to get influenza vaccine. So this includes long-term care homes, it includes hospital, people admitted to hospital, other people with high-risk medical conditions, healthcare workers, and people age 65 and older. As of October 27th, the general population will be eligible to access influenza. Often we receive questions about there's 2 main types of vaccines, high dose versus something called adjuvanted. There is no preferential recommendation of one over the other. They are both effective. And so when you go to the pharmacy to ask for the vaccine, whichever vaccine is available is the best vaccine to take at that time. It doesn't have to be a certain brand. Next slide, please, Wendy. COVID-19 vaccine. So there's two available, Moderna and Pfizer. Novavax used to be available in Ontario, but is no longer available in Ontario. Also, high risk and priority populations are eligible. The general population becomes eligible October the 27th. The current recommendation, because we know people are still getting COVID-19 infections, is that there's a minimum of 3 months between the last time you had a confirmed infection or highly suspicious illness that you think is COVID-19 and then getting the vaccine. You'll recall over the last 5 years, various time periods were recommended, 6 months versus 3 months, and back to 6 months. And so at this point in time, it's 3 months. It's like an RSV vaccine, two components, the adult program and the pediatric program. This year, the province is funding publicly all adults age 75 and over are able to access RSV vaccine, as well adults age 60 to 74 with certain high-risk conditions. This is primarily transplant recipients and very high-risk immunocompromised conditions. Boosters are not currently recommended. If you received an RSV dose last year, you don't need another dose this year. We think they're likely good for 4 to 5 years, but it'll be evaluated every year as we collect more data. Two products that are available, and there's not a preferential recommendation for either one. So whichever one is available is the right one to get. Next slide, please, Wendy. And then the pediatric component is the infant program. So infants born in hospital during the RSV season, the intent is that they receive a dose of this immunization prior to being discharged from hospital. So this will capture most infants born this season. If they're born at home or out of hospital or don't receive it at the time of discharge, they can access it through either a primary care provider or through the health unit if they don't have a primary care provider. Also eligible are children with high-risk medical conditions. So this would be heart problems, lung problems, until up to the age of 24 months. And pregnancy. So if a pregnant person decides that they don't want their infant to receive the vaccination, the pregnant person can decide that they wish to receive the vaccination if they're in their third trimester, so between 30 to 36 weeks. They're eligible for a dose of Rispo, the adult vaccine. It is preferred or more recommended, though, that the infant receive the vaccine, as it's there's greater evidence related to effectiveness. Next slide, please. COVID-19, influenza, RSV vaccines can be given at the same time. They are all in different needles. They're not in the same shot yet, but they can be given at the same time. So I think a lot of clinics are trying to make it as easy as possible and have them at least COVID-19 and influenza both available. In terms of where to access, so pharmacies are the mainstay for general population for influenza and COVID-19 vaccine. Many primary care providers also providing clinics for influenza and COVID-19. The health unit is providing clinics for children under the age of 5, and without a primary care provider, they can access these vaccines at specific health unit-led clinics. For RSV is not available through pharmacies. It is only available through primary care providers and or the health unit. So the health unit is offering clinics for, again, children under 5 without a primary care provider, as well as adults without a primary care provider. And if we go to the next slide, please, Wendy. In addition, we're supporting clinics in each of the First Nations communities that we're partnered with, Alderville, Hiawatha, and Kirk Lake, through in collaboration with their health centers or their health service teams. We have a handful of retirement homes that need RSV clinics that we're supporting clinics in, and then, as I mentioned, unattached seniors and children under 5. Next slide, please. So I want to switch to the next main component of our work, which is infection prevention and control. The former Central East IPAC Hub, which was hosted out of PRHC, or Peterborough Regional Health Center, transitioned to be hosted out of the health units last year prior to merger, jointly hosted by PPH and HKPR. It is now one Lakelands IPAC Hub. So it's been part of the branded, is now called the Lakelands Public Health iPad Hub. This service is a team of 4 dedicated people that provides iPad support to congregate living settings. So long-term care homes and other group home settings that are at higher risk of respiratory infection transmission. So they host community practice, they host education series, they can provide on-site support services with the intent that if there is an outbreak of a new respiratory infection, that we will not be facing the same challenges we did at the beginning of the COVID-19 pandemic. So major lesson learned and implementation strategy moving forward. Another component, moving on to outbreak management, role of public health. So this is primarily settings where outbreaks are declared in long-term care homes and in hospitals. On our new website is the list of any newly declared outbreaks. So if you're curious as to where existing outbreaks are, you can go to that web page. And we provide day-to-day support to those settings to manage their outbreak and make recommendations regarding control measures to prevent further transmission. And as always, as part of our internal planning is our surge response plans and ability to scale up to unexpected increases in activity. Last topic I want to cover is communications. This is one of the largest communications campaigns the health unit does each year. Purpose to reinforce local, regional, provincial strategies. New website is being updated with material relevant to this year. Our social media feeds are very active for those people on, I know it's not Twitter anymore, X, Meta, X, thank you, Instagram, Facebook, there's lots of different sites. We have hosted a number of newsletters reaching out to primary care providers, childcare settings, school communications. And so really trying to ensure that people have the right information at the right time. So I want to speak very briefly about the Chief Officer of Health report, and my apologies, there's an error in the title of the slide. This is actually the 2025 annual report, which was focused on immunizations, which ties in very importantly with respiratory season, as that is one of our main mechanisms to prevent transmission in serious illness. There's 6 key recommendations that the Chief Medical Officer of Health made, and I think they're all very highly relevant to our region. Some of the most, I think, pressing of these recommendations is the need for a centralized provincial immunization information system, which is accessible to both individuals so that they know their immunization history, as well as healthcare providers and public health. At this point in time, we don't have that. It's very challenging. We have 2 different provincial databases. We have multiple EMRs across our primary care sector, and it makes it very challenging for patients and families and guardians of children that need to report immunizations to the health unit, for example. So flagging is, as we think it's important for the Board of Health to be aware of these recommendations and to also let it support and do what it can in advocating provincially for support of these recommendations. Also tied in with this is to Dr. Piggott's point earlier about the measles outbreak and the key role of immunization in measles control and prevention. So the provincial outbreak that was primarily in southwestern Ontario was declared over. However, we should and will continue to see sporadic cases of measles provincially, and we could see them locally at any time. There's still outbreaks in Alberta, British Columbia, and globally. At the end of this month, there's a reevaluation, and Canada is at risk of losing measles elimination status globally. What does that mean? It means that if we are no longer considered to have measles eliminated, there's a number of surveillance measures that then kick into effect and enhanced measures to see if we can reobtain elimination status for measles. So certainly a provincial immunization repository that was up to speed would help us in those measures as well. So I will end there and happy to answer any questions.
Thank you, Dr. Bocking. That was a very detailed presentation. Thank you for that. Questions from members? Edward Clark. I see the screen again.
So no. each individual variable needs to be looked at again and then ensure we're capturing it the same way so that we're comparing apples to apples. So it's lovely. It's on this beautiful dashboard now, but it was a huge amount of work to get it.
It's separated differently, so you really can't give an opinion.
I think we'll see. This will be an excellent first year of both the uptake in terms of number of visits to the site, like how is it being used, and then and what it shows.
To the chair,
Yeah, go
I
ahead.
have two affairs.
Yeah, go ahead. Yeah, follow up. Yeah.
So the Novavax, which is not available in Ontario, is that a supply? I'm just curious about the rationale why you're a province that doesn't offer that.
So it was a provincial decision not to purchase Novavax. So it was a policy level decision. I think there was very little uptake to justify provincial procurement of it, but I don't know the inner workings of that decision.
And my last
Yes.
question, if I may, so the RSV for infants in hospitals, how is the uptake on that? I know, you know, we're talking about vaccines in young, you know, newborns, and, you know, there's out there, say, on the web, wherever. Is there pushback, or are we getting a good uptake, or keep track of those numbers being offered, and there isn't a pushback?
So the target for this year is actually 90%, which is quite high.
Yes.
I mean, it's very high. The information is captured in a provincial database called FORN, which hospitals are already entering birth data in. So there is a good data source to capture it and monitor over time. I can't recall, and I don't know if Dr. Piggott, you recall the uptake last year. It was fairly good.
I'm happy to hear that.
Yeah. Compare that to influenza vaccine uptake, which has continued to decline annually since the COVID-19 pandemic, with adults age 65 and over only at 35%. And last year, and hospital admissions from respiratory illness was higher than certainly what we've seen in the last 5 years, and this year is predicted to be quite similar to last year. So increasing uptake of influenza vaccine will definitely impact burden on the healthcare system.
Big wait times in the emergency department and costs. Yeah. Thank you.
Your word, Dr. Litchfield next.
Thank you. Thank you, through you, Chair Black.
Yeah.
To Dr. Bocking, thank you so much for that detailed report. Just a question, just the respiratory outbreaks from 2019 to 2024. Really interesting to see those two broken lines. In comparison to other jurisdictions, is the pattern similar? Provincial patterns? Where do we stand with that? Are there similarities?
Yeah, I would say similar pattern to the province. There's so Public Health Ontario has a provincial tool that's publicly accessible that you can go on and look at the provincial trend, and then you can go on and look at each individual region. There are variations sometimes in the time of year that you'll see infections. Northern Ontario tends to see things 2 to 3 weeks later than Southern Ontario, as it takes time for the infection to come north, I suppose. But otherwise, this would be typical of most regions.
Thank you.
Thank you. Councillor Joyce.
Yes, thank you, through you, Chair.
All the raise.
Dr. Bocking, I was looking at the surveillance slide, and what really caught me off guard here, spicy, is the viral signal for COVID-19 really spiked in 2024. It's bigger than 2022. It's bigger than 2022. Thankfully, it's lower than 2025. But that's really surprising. I thought it would be, you know, bigger spikes in earlier years and working its way down. Is there an explanation for that, or?
COVID, so a couple of thoughts, and Dr. Piggott probably has been more involved in the research side of things, but relative to this. You'll remember that there's been different variants of COVID-19. And so we started with, you'll have to help my memory, there was Alpha, there's been almost every letter, Beta, Delta, right? And then finally Omicron. And so they became more and more easy to spread, but sometimes less, didn't cause as much severe illness. So it's not necessarily surprising that even in 2024, you're seeing a lot in the wastewater. And certainly we're seeing still hospital admissions and deaths, but not the same level as, say, 2022, where the level in wastewater is lower, but the number of people in hospital. We're also, in 2024 would have seen more immunity in the population from both vaccination as well as infection. So people that have had COVID-19 a number of times already. So I think it's not surprising that we're continuing to see a large amount in wastewater, and what it means from a systems perspective does change over time.
So we have COVID, but we're immunized, we built up antibodies, and don't even know we are affected at the time with some.
For some people, absolutely. We also are not testing as much. Right? We don't have rapid antigen tests the same way we used to. We're not testing the same.
But it's showing up in the wastewater. Okay, thank you.
Great question, Councillor Joyce. Dr. Makicha, your question?
I was going to say this is a very thorough report. I am pleased, and it's very informative. So there is nothing to question on it. It's just a very nice study for 5 years. Thank you.
Thank you, Dr. Makicha. Councillor Richardson?
Thank you, and through you, Chair. Just a quick question when it comes to the communications component on this great presentation. When we got this link of community outbreaks, Lakelands Public Health, are we pushing that out to our communication departments and our municipalities? Because I think, like you said, the engagement at 35%, if we provide more education and, more outreach to the community, we may see different level of engagement.
I think our communications team, now that we have the new brand, that we have the new website, is now embarking on this mission of really getting it out there. I think the other strategy that we use is sometimes together with Ontario Health teams to do it collaboratively. And I know that municipalities are also involved in Ontario Health teams and sit at that table and can be part of really joint messaging. So it's not just from public health, it's also from the hospitals and the family doctors and the paramedics all saying the same message.
Yeah, no, and I thank you for that. And it's good to hear. I just feel like right now is a really good opportunity to push out our new branding and, provide extra communication if we can.
Thank you. I got a couple I did see you on a post yesterday, actually. The colors, the new colors, the post jumped right out at you too. As long as with your picture, of course.
Right.
But it was quite good, actually. It was very well done. Communications folks, yeah. But we kind of had a conversation at one of our council meetings. It might have been county councils today, that not everybody's on social media. So again, we have to look at other aspects of how to get that information out to the public. 30-second, 60-second spots on TV, that sort of thing. A lot of people not on social media. So, quick question: the stats, this particular trend here, the COVID trend is coming down 24. Did it continue to come down in 25, or do we have enough information yet on 25?
We don't have enough information yet. We saw a slight increase over the summer, and I would expect in the fall we'll start to see an increase as well. Rise again. Yeah. Okay, thank you. There are no further questions. Can I get a motion? I'm going to thank you for your presentation. A motion to receive the presentation.
Mr. Chair.
Oh, sorry. I can't see you now. Sorry, Dr. Stelzer, go ahead. Sorry.
Yeah, thank you very much, Mr. Chair, and thank you, Dr. Bocking, for that presentation, which is very helpful. My question actually has already been partially answered, but I'm wondering, given that we're this time faced with, recurrence in COVID, especially in the States, and now we have to add RSV as well. Are we, and we're working on the communication part, but are we making any considerations for an open clinic anywhere in public health where people can walk in at lunchtime and so on and get vaccinated to whatever? And also, are we promoting the antigen testing kits again for COVID? Because anybody who has a cold nowadays, the first question is, are you sure you don't have COVID? So are there any what should I say, recommendations in that direction?
So the provincial testing strategy, to answer your second question first, is really a to treat policy, so that people, at least in the healthcare system, people are only being tested if they're eligible for treatment for COVID-19 or influenza, or we're using testing specifically to identify and manage outbreaks in long-term care homes. So most places don't have access to rapid antigen testing kits. Long-term care homes can still order them. The health unit does not have any rapid antigen test kits, and they're not widely publicly available. I think the guidance in general, though, remains for infection, that if you have a respiratory infection, that you're staying home if you're sick, regardless of what the source of the infection is. That if you've had a fever, you're at home for at least 24 hours until after the fever has disappeared. If you're still coughing, that you consider wearing a mask when you're, especially if you're in indoor crowded places. And in general, kind of personal masking decisions about what your own susceptibility is to severe illness, and those around you that you're spending a lot of time with and their susceptibility. So there's not widespread availability of rapid antigen tests. In relation to the first question, so a community-based clinic. So at this point in time, Lakelands Public Health doesn't have plans to have either a mass community clinic or a walk-in availability clinic. We don't have capacity to do that at this point in time. COVID-19 and influenza are very easily accessible through the pharmacy. And most even kind of small towns have pharmacies and have those available at those locations. We have contingency plans if there was a sudden surge in kind of pandemic planning for the health unit to be able to offer that service. But in terms of competing demands, at the same time as offering all of this, we're also implementing our school immunization program where we're immunizing all grade 7 students. We're preparing for the enforcement for Immunization of School Pupils Act. So this is all kind of competing priorities on a team that has limited resources. So at this point, there's not plans in place for a wide eligibility clinic.
Thank you.
Thank you for that. Thanks, Dr. Stelzer. Vice Chair Ryle, Councillor Ryle.
Yeah, I think if I'm not misunderstanding what you're saying, Dr. Bocking, a lot of this is just resources that we just don't have. And in regular, I don't want to say it's important because it certainly is important, but in perspective to what else we have going on, it's now been considered more of a regular routine thing. And I think what you're saying is in the event that it escalates to a higher level, then we would obviously find and do the funding for that. But to just arbitrarily go into a more public application, is it mostly related to the fact that we just don't have the resources to do it, and the province doesn't seem to be in that mood to grant us anymore?
I think that's an accurate description. We don't have the resources for wide clinics. We are already playing a role of the people that don't have access to primary care and providing clinics there. So I think we're doing what we can where we can.
Any questions? I'll move to the motion. To receive presentation for information and Warden Clark. Can I get a seconder? Anybody seconder on the screen? Mayor Olina Hutchinski, seconding. All those in favor? Thank you. All right, so we move to 7.2 is the report of the Stewardship Committee on the budget. Chair Ryle, I'm going to ask Larry to start with the presentation. He's got a couple of slides, and then I'll invite you certainly to jump in, unless you want to do it in reverse order.
No, I think that's a great way to do it.
Okay, thank you. Mr. Stinson.
Thank you, Chair Black. So to start with, the staff were given direction at the last board meeting to come back with a draft 2026 cost share budget for this meeting and to base that on the approved levy harmonization plan. So I'll just provide an overview and highlight some of the changes from 2025 and then have to answer questions if there are. So to begin with, when you look at the total revenue that we have of 30.8 million for 2026, this is a 3.7% increase over 2025. So this is what you would say is determined by the expenses that we would have to maintain the minimum service delivery levels. So that revenue is based, first of all, on the 1% increase from the province that we knew from years ago. They said it would be 1% increase in 24, 25, and 26. So this is the last year of that plan. The 10.6% that you see from local funders is that mix of the 5% increase across all local funders, and then the 15.7% increase for the levy harmonization for the legacy Peterborough Public Health funders. There's also a 6.7% decrease in offset revenue. So just to provide a brief explanation of that, we have a small number of programs where there is revenue generated, such as our oral health program. So just based on past practice and knowing what we anticipate, we would predict a $50,000 decrease in that, and that is actually a historical thing. It was balanced out in the last few years by putting in some deferred revenue into the offset revenue account, so that balance there, that's zero. But we wanted to reflect the actuals, so we moved that $50,000 out of that line. On the expense side, the wages and benefits, no surprise, are the biggest cost. So over 80% of our expenses come from wages and benefits. The 4.8% for wages, that includes real and anticipated wage increases as part of negotiated agreements, as well as the full application of the non-union wage harmonization that was undertaken earlier this year. The benefits, those are like out of our control kinds of pieces, like OMERS, which is tied to wages. So when wages goes up, OMERS goes up, and our health benefits continue to go up year after year, often with increases of 8 to 12%. And it's also based on our experience from year to year. So that really hasn't settled out under Lakelands, but we will get a better sense of that in future years. So most of the other expense lines we've held at 3%, which we would say is cost of living and based on the inflation rate that we've been seeing. And then there's a few that have changed outside of that 3%. So occupancy is only 2%. And that's based on actuals. So when we look at the lease agreements that exist and what we know will be increases in 2026 and what our condominium fees will be, that leads us to a 2% increase. There's a couple that are related to some of the changes we're seeing through the merger. So on professional services, we've seen that decrease, and it's mostly savings from insurance and other contract consolidation. And IT costs, similarly, we're seeing a decrease in 2026 as we move through the first phase of integration. It won't be complete integration and full cost savings in 2026, but we are seeing some, so that's been applied as well. So I do think it's important to note that if it was not for the increases related to the levy harmonization, we'd be facing a significant challenge. The additional $530,000 that we're getting in local funder contribution means that we're only asking for 5% across the board as a base increase to reach that 3% increase overall for our budget. And it really does highlight the fact that year over year, 1% or historically 0% that we get from the products does have a huge impact on our either service levels and or our local funders. So the visual that was included on page 39 of the agenda really is there to reflect that shortfall in the provincial increase for 2026. So if you had seen a proportionality of sharing that increase of 3.7% and at a 75-25 mix, which the province has stated is the appropriate mix for public health, it would be quite a different picture than we're actually being. So it is a good thing for 2026 that we are able to balance out the budget and apply the merger funds with mitigation funding back to municipalities. And I hope that paints a good picture of the budget for you, and happy to answer any questions if there are, or actually pass it over to our chair. Let's do it first.
Yeah, thanks, Larry. Yeah, Councillor Ryle, go ahead.
Yeah, I think Larry has basically summarized this pretty good, and I think it's extremely important that we pay attention to the fact that there are two different numbers here that are working against each other. One is the actual expenses, which we have held at 3.7, and I mean, there's obviously places where we should or could or might be able to cut that slightly, but at the end of the day, you got to bear into the mind that we're also in transition, and for us to be able to do and hold a 3.7% increase in expenses to me is really a solid a movement. Most of our municipalities, I know ours specifically, I don't think we're going to be able to get even close to 3.7% for 2026. Just my thoughts out there. And at the end of the day, our problem is not related, as Larry was saying. It's related to the way the funding formula works. Because the province pays or contributes roughly twice what each of us do, then what happens is when they cut their funding to 1% against our 3.7%, somebody's got to make up the difference. And they will not let us run a deficit. So consequently, that means we have to come up with a differential. And that's why it gets jumped so high in the actual contribution from each of the various funders. So it's really a question of did our budget people who put the numbers together do a great job of keeping our costs as low as possible? I think they did. Having said that, the problem is not with them. The problem is with the fact that the province would not come to the table with their 3.7%, which leaves us in a shortfall position. So again, we looked at that. I think the way that we've looked at the overall using of the merger funding has been excellent as well. I realize that that's a significant increase for the Peterborough people. But having said that, you're getting the money from the province, which then you can use to the way you choose to want to. You can either apply it to the actual levy, or you can prorate it, or you can use it for any other purpose that you choose to. At the end of the day, it makes a big difference. And for those of us in the HKPR or former HKPR, you can see that it also changes the differential that we each pay, moving it in the direction that we were trying to go. So I really think that Larry and his team have done an unbelievable job. And again, please bring any questions forward. I'm the layperson in this deal, so Larry will probably handle most of the questions if they come into the financial.
Thanks, Councillor. We'll let the hard questions go to Larry, and then the softballs we'll send over to you. So just from a numbers thing that's not on here is the percentages in this budget. The province is at 68.2%, and the local funders are at 31.8% now, from a 25-75 split. So I'm going to go with Councillor Joyce first. Nice. The other hand.
Okay. I got one more question.
Yeah.
First question, with the benefit plan, do we shop around going up like the 10 and 12% per year? Do you shop that around to? When I was with a private company, it changed every other year because they shopped around. Now there might be negative side effects to switching all the time. I don't know.
So, through you, Chair Black, through the chair. Our benefits program, health benefits, extended health benefits are through a broker, Mosey & Mosey. They do the shopping around for them. And there are 13 health units from across the province that are part of that collective, so that gives us some added purchasing value for them. And again, through that though, we would have our increases year over year are based on our actual experience in the year before, based on, as well as some collective experience across the broader group. So shopping around can help, but our brokers have told us year over year, like if you did that every year, you would go out the next year and nobody would take your business.
Yeah.
So so you do need to consider when you do that, and you often do see you might have 1 or 2% increases or held at 0% for a couple of years, but then you're going to get hit with the 12 and 15% ones. And I know some of the health units had even close to 25 and 40% increases for a couple of years. So And there are drivers behind all of that too, like drug benefits that are costing more, some of the expensive drugs that get used more. That's an experience factor that will come into play.
Understood. Thank you for that. And it's right.
Matthew, like he had some other.
Yeah, I was gonna ask Matthew if he had anything to add. I know.
Experience too.
The one element I wanted to add is that we did have, before we have this discussion, when we work in the consortium, we go in sort of five-year blocks, and we're coming to the end of our block. And so often you get what's called a marketing discount through those first few years where your rate inclusions are capped at a certain percentage. And then comes home to roost a little bit in the last couple of years. So the answer around will we be going out to market, I believe that's on the table in the next year with the consortium.
Very good. Very interesting. Thank you for that education. The company has looked with 20 people, so it's a little different.
I'll add one final thing which Larry commented on, but I think it's critically important to kind of appreciate the risk of going out to market and not getting a respondent is that you're self-insuring at that point. And that can be wildly expensive. And some of the products we use are something called stop loss insurance, which means for really expensive drugs, it caps us our exposure at about 20,000 or so. But if in the absence of that insurance, for a health unit our size, it could be devastating.
Thank you. Thank you. Second question.
Yeah.
Second of 3 questions. Through you, Chair, the Board Health Committee, $38,000. What do we spend? Surprised to see that. What are we spending that on? I know we have retreats.
Honorariums, my car.
Your first class track.
No, it's honorariums for committee members, that sort of thing.
It adds up.
Travel, mileage.
We don't have that.
When we have 17 members on this committee, on this count, there's,
Okay.
that's it pretty quickly. Yeah.
Our mileage, should we be billing it to the board?
No,
No.
no, so that's the
Yeah, that's our mileage, right? Yeah, delete.
We're fine.
Yeah, we're good.
Yeah.
You have another question?
Third question and last one, thank you through you, Chair, is the per capita between the two legacy boards is current, the differential right now $6.10. Just curious, what was the differential in 2025? I don't know if you have that number with you, right?
Roughly.
And we're closing the gap, I assume. Right?
Yeah, it'll be closed in the 5 years that the plan shows, so.
Okay.
Yeah, what the
Per capita for the legacy Peterborough funders was 2760. No, that's sorry, 2026.
Yeah.
No, I don't have 25. Sorry, I have to go back and look at the.
Yeah, if I remember, it was about $10 difference, $9 or $10 difference. So, yeah, so between last year and this year, we're at 23 something, yeah. And
Okay. Thank you very much.
have a question on the board. Cecil, go ahead. Sorry,
I was
John.
going to say that was one of the things that we just. That was one of the things that we discussed, was that I believe that the differential is going to drop about $3. Originally, when we were going a 5-year plan, we were trying to do it with the idea of $2 per year. In 2025, we made a decision not to change anything because it just wasn't. There was not enough information that we could realistically start looking at it. But the way that we've used the merger funding has enabled us to be able to do that without hurting. I mean, obviously, the former PDH people are going to be paying more for sure, but the amount that we were able to reduce that by through the funding was awesome. So for those that are interested in that, I believe the number is around $3 reduction in the difference at this point in time. I could be wrong. There's probably cents involved there too, but I think it's around $3.
Probably close to the 4 based on the math I see, but thanks, it's Councilor Ryle. Mayor Logan.
Thank you, Chair. My question is regarding the 2 streams of funding from the province. There's one that they call a standard funding, and I believe that's to do with the laws of the provincial health board. And then there's a second one that's for initiatives. Is there a reason for having the two different ones, and is it based on fluctuation between one board and another board, or?
Through you, Chair. I might ask for clarification that in general, in our annual service plan, we will get base funding and
Yes.
one-time funding. Are you referring to one-time funding?
Yes.
Okay. So one-time funding is either generally targeted towards something that is seen as not an ongoing need, or that the ministry will use what they anticipate would be some surplus, like they budget their full amount that they get from the ministry. But if some health units can't use their full amount, then they'll reinvest that back into one-time. So they are predicting how much might be underspent so that they can support one-time initiatives. And they will have told us, like that used to be a more significant amount. They used to have more health units that didn't fully expend their funds, and there'd be more available for one-time, and you could apply for that throughout the year. They would even predict it when we submitted our annual service plan that they're going to have some. Now they limit it to very small number of things like our inspector placement program. What else? Used to be needle exchange. Just a very few items that you're allowed to submit one time for. So it's really gone down.
And it's not senior dental or something like that?
And seniors dental is 100% funded program by the province.
Okay. Thank you.
The more special project type things.
Yeah.
Yeah. Are there any other questions? I saw a bunch of hands very early, but maybe we've answered some of those questions. Anybody on screen? Don't miss anybody again? No? Okay. All right. So we're looking for a motion to receive the staff report for information and approve a cost shared budget of $32,836,400 for 2026 as outlined and recommended by the Stewardship Committee. I have a mover for that. Logo and a seconder, Dr. Makicha. Thank you. Any further discussion? All those in favor? See some hands. Thank you. That's unanimous. All right. Wonderful. That's a big piece of work done by Stewardship Committee, and I want to commend them. We've had some challenging talks and some challenging issues through that, and I commend the board and all the members that sat and came to consensus on getting moving forward, so we can focus on other parts of our mandate as a public health unit. So appreciate all the hard work of your committee, Councillor Ryle. All right, let's move to 7.3, which is policies for approval. And there are two policies that were circulated prior, which were the Code of Conduct and Pecuniary Interest policy. Everybody had a chance to a good bedtime reading on a couple of these. Any questions on the policies? Any changes, concerns? All right. Do you want to speak to anything? Yeah, just briefly. Yeah.
Yeah, but thanks to Alina and Matthew for lots of work, both looking at how we historically had done this, but also, the merger's an opportunity to also look outside and look for new ways of doing things. So we did do some consultation with other health units and even looking at municipal best practices around these two policies. So you'll find them as written, and we met with the chair and vice chair earlier to incorporate a few changes as well. So I think it's fairly clear. I just wanted to highlight this is part of our continued schedule. Obviously, January 2nd, 2025, our first board meeting, we met. We approved all the minimum bylaw and policy requirements that the new board had. And now we've been sequencing in to get a full slate of policies, and this is where we're at now. So we're not done yet. We'll still have a number to do later this year and for next year, but this is making progress in that regard. Thanks.
Yeah, I want to thank Alina as well. Turning these out, they're not easy. We did review them the other day, and there was a couple of very minor changes. She did a fantastic job on everything that's merging, trying to merge two policies together into one that works for the new board. So thank you for that. So, all right, so we need a motion to approve conduct and pecuniary interest policies. Can I get a motion to approve? Dr. Stelzer moving, seconded by Councillor Wilson. Any further discussion? All those in favor? Thank you. Fantastic. Okay, so consent items, item 8, there are 3 consent items. One is correspondence for direction. 2 is the Indigenous Health Advisory Circle meeting minutes and stewardship meeting minutes. Any discussion on any of those? Seeing none, I'll ask for a motion to receive the consent items or approve the, what is this motion, approving or receiving here? To receive. Yeah, to receive the 3 consent items motion. Member Clark and Councillor Richardson. Any other discussion? All those in favor? See some hands. Thank you.